We're now in the video record. This is the video deposition of David E. Kaplan, MD, taken by the plaintiff in the matter of Cynthia Allen, individually and as PR of the estate of Dennis Allen, et al., versus Alan Burks, MD, et al., in the Circuit Court for Baltimore City, case number 24-C-15-003384-MM, held at the office of JD Reporting on 1880 JFK Boulevard in Philadelphia, Pennsylvania, on Wednesday, June 8, 2016 at 12:17 p.m. I am Eric Bensavengo, the videographer. The court reporter is Kathleen McHugh. We're from the firm of JD Reporting. Counsel, will you please introduce yourselves for the record?
Justin Zuber on behalf of the plaintiff.
Good morning, or I guess good afternoon. Ronald Shaw on behalf of Dr. Burks and University of Maryland Medical Systems.
The court reporter will now swear in a witness.
Sure, your writing, please, Doctor. Do you swear the testimony you're about to give will be the truth, the whole truth, and nothing but the truth?
Yes.
Thank you.
Good afternoon, Doctor. As I said, my name is Justin Zuber, and I represent the plaintiffs in this case. Have you ever had your deposition taken before?
No, this is the first time.
Okay. Some ground rules. As you can see, the court reporter is diligently trying to take down everything I'm saying and everything you're responding to with regards to my questions. For that reason, it's very important that you allow me to complete the question before you begin your response, and I'll try to do the same courtesy, okay? Another ground rule. Make sure that when you respond to a question, you don't say uh-huh or nod your head or shake your head. Obviously, she can't actually type that down. With regards to the questions, if at any point you're not clear on a question, just ask me and I'll try to rephrase it for you. Also, if at any point you need a break, just let me know, okay?
Noted. Thanks.
All right, Doctor. Can you tell me on an annual basis, how many medical legal cases do you think you review?
For tort cases between 0 and 1, I do very small volume. Most of the legal work that I've done has been for the state of Pennsylvania, reviewing medical negligence cases after the fact to determine whether or not physicians pose a danger to the public and require specific monitoring by the Department of State. So I've provided information about the cases that I've done. It was more prior to 2010, and there's a handful of those cases per year that I do. Most of the time when I get approached I get approached for plaintiff's cases, and I generally will not review those.
Okay. With regards to the tort cases, you just said that for plaintiff's cases you generally don't review them. Is that what your testimony is?
Generally, I'm in the process of reviewing one case that is a plaintiff's case. I have not been actively soliciting expert work for in general, if I'm, I try to take cases in which I think I actually have something relevant to have comment about, and that it's that there are issues that unfortunately in medicine, bad outcomes don't necessarily mean that someone did something wrong, and that there's necessarily malpractice. And generally, when I have been approached, obviously cases are brought because there are bad outcomes, but that doesn't necessarily mean the physicians have been negligent. And so I think it's very challenging ex post facto to except in episodes where there's clearly gross negligence to point fingers. And so it's generally been my personal philosophy to try to make sure that if I'm going to be involved, it's because there's something that I truly feel is negligent, and generally that's not been what I've been presented with.
Okay. Fair enough. So if you were approached to review a plaintiff's case, though, and you thought it had merit, that would be a case that you would consider reviewing and testifying in?
Yes, and in fact I'm involved currently in the review process of such a case. It has not gone to deposition yet.
What's the nature of the case that you're currently reviewing for a plaintiff?
Well, I have concerns about that. He can answer whether or not it involves issues similar to this case, but otherwise for him to give sworn testimony in a case where he might not even been identified as an expert yet, I have concerns about that. That might not be At least under Maryland law, I don't think that's discoverable. So,
Well, let me rephrase the question. The case that you're reviewing now for the plaintiff's attorney, does that case deal with any of the issues that pertain to this particular case that we're here for today?
Absolutely not.
Okay. Have you ever reviewed a medical legal case before dealing with hyperkalemia?
No.
Have you ever reviewed a medical legal case before dealing with Kayexalate?
No.
Have you ever reviewed a medical legal case before dealing with ischemic bowel?
No.
Although I don't expect your answer to this question is going to reveal that there's very much income from this particular source, but can you estimate for me on an annual basis how much of your income comes from medical legal cases?
Generally less than $5,000.
I know you told me that you've never been deposed before, but have you ever testified at trial before in a medical legal case?
No.
Have you ever been sued for malpractice?
No.
All right, I'm going to show you what's been marked as exhibit number 1. Take a look at this for me. Is that a complete and up-to-date copy of your CV?
It appears this is dated 10/21/15, but other than a few possible publications that have come out since then this is a accurate representation, yes.
With regards to the publication specifically, do any of those items deal with hyperkalemia, Kayexalate, or ischemic bowel?
No.
Do any of those articles deal with any of the issues that are involved in this particular case?
No.
All right, let me just take that back here. And what states are you licensed in?
Just Pennsylvania. I
Okay.
have an inactive license for New Jersey, and I was originally licensed in Maryland, but that is not active.
And I'm assuming that your license has never been suspended or revoked,
No.
and you've never been reprimanded by any sort of board of physicians or anything like that?
No.
Okay. And you're currently board certified in internal medicine, gastroenterology, and hepatology, transplant hepatology, and it looks like you recertified in internal medicine. Is that correct?
I recertified in 2010 with internal medicine, 2014 with gastroenterology, and I will recert later this year, well, I intend to recert in transplant hepatology at the end of this year.
Okay. Can you tell me what items you reviewed in preparation for your deposition here today?
So I reviewed the entire volumes of Mr. Allen's chart, which were labeled as volumes 4 and 5. I reviewed the testimony of Dr. Burks and Dr. Diamantidis. I reviewed the testimony of Dr. Odzi, Dr. Goldstein, Dr. Stearns, and Dr. Leo, the depositions of those cases. And then there were some other sources of medical literature that I reviewed in the cases, which, in addition to the ones that they provided as part of their depositions, but also some materials that I brought with us, and there were some articles that I reviewed in the literature, including those that were provided there, and also we would specifically reference the editorial from Watson et al. In 2010, entitled "Damned If You Do, Damned If You Don't," because I think it really gives a clear explanation of some of the areas of discussion in hyperkalemia and management of hyperkalemia with sodium polystyrene sulfonate preparations.
is he talking too fast? He's okay.
I'm okay right now. Thank you.
Okay.
Just be careful, because if you talk real fast, then you tend to talk sort of fast. She may have a more difficult time.
I will
recording.
make an attempt to slow,
Yeah, should be a
slow
little
my
more-
cadence.
Be a little more cognizant.
Okay, I apologize.
With regards to the article, "Damned If You Do, Damned If You Don't," can you tell me what it is about that article that you found relevant to any of your opinions in this case?
So that article gives a very nice summary of the existing clinical data regarding the controversy that has been brought forward about the causation the causative relationship between sodium polystyrene sulfonate resins and ischemic injury of the bowel. It also discusses many of the issues that have been brought up regarding the utility of K-Xylate in acute hyperkalemia and the issues regarding the medical decision making that occurs during an acute hyperkalemic episode. Those are the relevant factors that I found relevant in that particular article.
In your practice, when did you first become aware of an association between the drug K-Xylate and necrotic bowel?
So in terms of a date, I cannot recall a specific date at which that association was first brought up. As a house officer, when I was training at Johns Hopkins, Dr. Lillemoe's experience was known, and that there were specific circumstances in which the sodium polystyrene sulfonate or K-Xylate preparations were known to be contraindicated for utilization, being in postoperative patients, and particularly with rectal administration. The controversy at that point was, and I think it's still controversial, is whether or not the resin itself or the sorbitol concentration was the idiopathologic aspect of that preparation. But during my internal medicine training and subsequently, that was the extent of our knowledge of any potential association. In terms of it wasn't until this case was brought up that that I was aware of any putative association when administered in non-operative patients with oral administration in acute hyperkalemia, that there was any evidence of any association. Although I don't believe that evidence substantiates that there is substantiates that there is a definite causal relationship.
So is it your testimony that, in your medical opinion, that there does not appear to be an association between K-Xylate and necrotic bowel?
There is evidence that when administered in postoperative patients, in my medical opinion, there has been an association of intestinal necrosis when K-Xylate has been given to postoperative patients or those with small bowel obstruction or ileus. Outside of that, my medical opinion is that there is not a well-established causative relationship between the administration of K-Xylate preparations and intestinal necrosis.
But you would agree with me that there is a body of medical literature out there that suggests that there is an association between K-Xylate and necrotic bowel, even in non-operative patients.
There are collections of case reports which are really not definitive evidence of any association. And that's really because one doesn't know the denominator of the cases or other confounding variables that could be impacting what's occurring in those cases. And so, typically K-Xylate is administered in patients who are pre-dialysis patients or approaching dialysis, or those individuals who miss dialysis sessions, often in the setting of acute medical illnesses where there are multifactorial events occurring. And when one takes a case series of cases from a tertiary hospital and compends them together, that's what you get. But unless you have unless you know how many doses were given in identical situations in which the event of interest did not occur, you really can't assess and the other confounding variables that occur in those cases. You really cannot assess whether or not there is a true causal relationship.
You kind of alluded to it, I think, by what you just testified to, but what kind of study would it take in order to establish that causal link so that it would be convincing for you?
So, this is a situation that obviously there never would be a randomized controlled prospective trial in this setting. It would be unethical, and no investigator would ever concur to be part of that type of investigation. If one is a purist, it would be very difficult to establish that. However, stronger evidence could occur, could be generated by large case control studies in which identical patients with and without the exposure are observed for the event. To my knowledge, no such study exists currently, and no such study existed in March of 2013 when this event occurred.
I want to ask you about a few of the articles that I think you are going to intend to rely upon at trial in this case. The first one that I have here is entitled "Right Colonic Involvement is Associated with Severe Forms of Ischemic Colitis and Occurs Frequently in Patients with Chronic Renal Failure Requiring Hemodialysis." And I'll mark this actually as exhibit number 2. I think you have a copy of there, don't you, Doctor?
Unfortunately,
Oh, okay.
I don't
Well,
have.
if you want to look at...
There's an extra copy here somewhere, isn't there? Here it is.
Okay, so I'm sorry. I apologize.
Yeah, just briefly, if you can tell me what it is about this article that you intend to rely upon in support of your opinions in trial.
Okay, so this is the Flaubert
Mhm.
paper. Okay. So this is a case series from the GI literature from the American Journal of Gastroenterology in 2000, looking at 60 patients who were inpatients who were undergoing hemodialysis and who developed ischemic colitis. So the total N of patients with hemodialysis is not known in this case, but these are individuals who were on dialysis who developed ischemic colitis because the literature does support that there is a potential association between being on dialysis and the risk of ischemic colitis. And these individuals were evaluated for different risk factors for having either moderate or severe disease. They provided an estimate of the risks of this event occurring with dialysis. But the main issue here that's brought up is that individuals who are on hemodialysis who develop ischemic colitis are more likely to have severe disease, more likely to involve the ileocecal area of the colon, and to have a high mortality associated with such events. The other important point to bring up here is that these are individuals. There's no data presented here that KX-late or any polystyrene sulfonate exposure was necessary in these cases to precipitate ischemic colitis. Now, it's possible that in these cases had other issues, multifactorial causes of hypotension that led to the ischemic colitis, but the main factors here are that patients with on hemodialysis are at risk for ischemic colitis and at risk for more severe disease.
With regards to ischemic colitis, what causes ischemic colitis?
So ischemic colitis in this setting is referring to non-occlusive mesenteric ischemia. The colon is supplied by 3 main blood vessels: the celiac axis, the superior mesenteric artery, and I'm going too fast, the inferior mesenteric artery. these supply 3 separate points of the colon and small bowel along the mesentery. Between these vessels, there are smaller palisading vessels called the vasa recta. Particularly in the areas that are at a distance from the 2 inflows, the vasa recta getting to those areas are very long. And what can happen in the setting of hypotension in particular, although there are other potential precipitating factors, prolonged exercise, and other stressors, the vasa recta spasm, and that then leads to reduction in blood flow to the mucosa. Typically, it's not a transmural injury. The wall is less sensitive than the mucosa to ischemia, but in the setting of low blood flow, which can be for as short as 15 minutes, the mucosa become damaged, the cells begin to die and slough off, and then at some point later, and we really don't understand the kinetics very well, when the vasospasm releases, there can be then bleeding from those areas of the colon. But the predominant mechanism is vasospasm.
Is it your opinion in this case that Mr. Allen developed ischemic bowel as a result of hypotension?
It is my medical opinion that that was an important contributing factor to his development of ischemic bowel.
What were the other factors?
The other factors that I think are relevant in this case would be that he had altered splanchnic circulation.
That he had, I'm sorry.
Altered splanchnic circulation due to his underlying liver disease. That he was having a severe inflammatory reaction in the setting of rhabdomyolysis, and there were at least 2 episodes of hypotension documented on the morning of the 18th that could have been contributing, or likely to have been contributing factors to this event.
Let's talk a minute about hypotension. What is your definition of hypotension?
So typically when one talks about ischemic injury to the bowel, one is talking about mean arterial pressures in the low 60s, 50s to low 60s being below a level necessary to maintain the integrity of the bowel.
Is it mean arterial pressure that matters more than systolic or diastolic?
I don't know if I can offer a medical opinion about that particular aspect, but generally, we would. I don't think I can offer a medical opinion about which is more important, systolic or diastolic pressure.
You said that Mr. Allen had 2 episodes of hypotension on the morning of the 18th. Can you tell me what specific times those 2 episodes occurred?
So there was one blood pressure that was documented at, I believe it was 90/40 at the time of his hyperkalemic event, which was at 12:27. And then earlier that morning in the nursing note, there was a documented low blood pressure of 100/40. The time for that event is not documented, but it was sometime between 9 and 12 based on the notation.
In your review of all the medical records, and there's been a lot of medical records obviously in this case, were those abnormal blood pressures for Mr. Allen?
Yes, so he had during dialysis on the March 15th, he had mean arterial pressure from 59 to 62 at the beginning of the dialysis run. But throughout most of the hospitalization, his blood pressure was running 110 over, in the 110 to 50 to 60 range from most of the blood pressure readings.
Do you know how long those 2 episodes of hypotension on the morning of the 18th lasted?
It is not documented.
How long would it have to last in order to contribute to ischemic bowel?
As little as 15 minutes.
Do you have any evidence in the record that those 2 episodes lasted anywhere close to 15 minutes on the morning of the 18th?
It's not documented.
So is it your assumption that they lasted that long?
I can't assume or not assume how long they lasted. It's not documented.
Okay, so you don't know.
I don't know.
Okay. Is it your opinion in this case that Mr. Allen developed his ischemic bowel on the morning of the 18th?
So the answer to that is no. I think he developed his ischemic bowel late that evening when his pain complaints began in the middle of the night. It's documented on the 19th. And so it is, I think, more likely that his pain, that the pain manifestation was a result of vasospasm and the acute ischemia at night. But what precipitated that is not clear.
Besides the 2 episodes of hypotension that you mentioned on the morning of the 18th, what other things happened on the 18th that would have led to his development of ischemic bowel?
So he underwent multiple medical interventions to try to treat the hyperkalemia. He underwent initiation of a session of dialysis, although during that dialysis session, his mean arterial pressures were all documented over 70. But he was having a much accelerated increase of his rhabdomyolysis on that day. His creatinine kinase levels went from 2,100 earlier to 56,000 on that day. So there were the background injury in this case. There is evidence that it was accelerating. It's not known if this was a statin-induced myositis or an inflammatory polymyositis related to his underlying hepatitis C. It's not known, but whatever process that was getting worse at the time when these events occurred.
Okay. Let me come back to that just in one second. What is a pressor?
A pressor is a blood pressure medication, a medication that's administered to increase blood pressure. These are typically either analogs of epinephrine or vasopressin, and they cause direct vasoconstriction of the mesenteric vessels, as well as other vessels, to try to increase perfusion to the heart and brain in the setting of hypotension.
In response to those 2 episodes of hypotension that you identified on the morning of the 18th, was Mr. Allen given pressors?
No,
Do you know why?
I do not know why.
Would you expect that if he was really suffering from significant hypotension that they would have put the patient on pressors?
Typically, one will, for making a decision about pressors, there is usually has to be some other clinical indication other than blood pressure. So that would be altered mentation, signs of peripheral hypoperfusion. But most patients who develop ischemic colitis don't have those other manifestations of hypotension prior to their presenting with ischemic colitis. And so the degree of hypotension that can lead to ischemic colitis is in the vast majority of cases not enough that would have prompted pressor use prior to the event.
Is your opinion that in this particular case, knowing what you know about Mr. Allen, that hypotension by itself wouldn't be enough to cause his ischemic bowel?
Hypotension in and of itself?
Yeah.
Now that would be potentially enough to cause it in any patient, including Mr. Allen. But in his case, there were multiple other factors at play. He was an extremely ill person with very advanced multi-organ failure, liver failure, kidney failure, and that would put him at higher risk of ischemic injuries in general, particularly the chronic kidney disease.
That kind of leads me to my next question, though, Doctor. In your review of the records, did Mr. Allen suffer from episodes of hypotension on any other occasion than on the 18th?
So the one other episode that there was documentation was at the beginning of his dialysis session on March 15th.
Why didn't he develop ischemic bowel because of that episode of hypotension?
I don't know.
Would you agree with me that his blood pressure levels on that particular occasion, and you can look at the records if you'd like to, were similar, if not worse, than his presentation, the 2 episodes that occurred on the morning of the 18th?
The blood pressures themselves were similar, but he was much sicker at that point.
Okay. So it was not just on this particular occasion on the morning of the 18th, it wasn't just the hypotension, it was some other factors that were coming together, in your opinion, that were leading to the ischemic bowel.
Yeah, so he was getting much, as I mentioned, his rhabdomyolysis was worsening. His mental status, as reported by the nurses, was getting worse. Because of worsening hepatic encephalopathy over the course of this time, he had not been dialyzed for 48 hours at that point. All these factors could potentially be contributors on that day. He was a much more ill patient on the 18th than he was on the 15th.
You said that he was having, I think your words were, an inflammatory response to the rhabdomyolysis. Is that what your testimony was?
The rhabdomyolysis was thought potentially to be an inflammatory event. And the plan in his case was to get a muscle biopsy because they were concerned that he had an inflammatory polymyositis. Had that proceeded, that would have altered, many of, if that had proceeded and been confirmed, that would have altered the direction that the team likely would have taken in terms of therapy. That biopsy never occurred. So at this point, it's hard to know if it's impossible to determine if this was a statin-induced myopathy, because he had been started on atorvastatin about a month prior to this presentation, or an inflammatory condition.
Do you intend to offer an opinion at trial as to the cause of the rhabdomyolysis?
Only that these were the 2 opinions that were brought up in the chart, and there are 2 reasonable medical, that's a reasonable medical differential diagnosis in this particular setting.
What is the basis for your opinion that his rhabdomyolysis was getting worse on the morning of the 18th?
His creatinine kinase level had been running 9,000, 21,000, and on the day of the 18th it was 56,878. So that was going up. On the 17th it was 48,000. So there was a steady increase over the course, and nearly a doubling of that level, more than a doubling of that level from earlier on in his hospitalization, without a clear reason.
Okay. Anything else besides the creatine kinase level?
I mean, that he was getting weaker by the documentation, but the main evidence for that is the creatine kinase.
You would agree with me that the patient didn't start showing signs and symptoms of ischemic bowel until late in the afternoon or the evening of the 18th, correct?
The documentation suggests that it was in the evening, but exactly what time, it's hard to pinpoint exactly what time the symptoms began.
And just so I'm clear, you would also agree with me that he didn't develop signs and symptoms of ischemic bowel until after he was administered the drug Kayexalate?
That's a matter of the clinical record. So yes, he was administered Kayexalate.
He was.
He was administered Kayexalate on March 18th at approximately 1:15 p.m. and that preceded his presentation with ischemic colitis.
So we dealt with this one article here. I want to ask you about this other one that you have. We'll mark this number 3.
So this is the Quiroga.
Yeah. If you could just tell me why this article is important to your opinions.
So this article is important to the opinion, again, regarding the issue of the association of hemodialysis and ischemic injury of the bowel. This reports a series of 57 cases, and based on their denominator, they make an estimate of the incidence rate of ischemic colitis associated with hemodialysis occurring at about 2.29 per 100 patient years of follow-up.
So that tells me a little bit about the study, but why is it important to your opinions?
Why is it important? Because it speaks to the other possible explanations for ischemic colitis in this particular patient, independent of the putative association with KX-LA.
Is there any data in here in particular that you're going to reference and say these are the things that clearly demonstrate a connection to his ischemic bowel, Mr. Allen's ischemic bowel?
Primarily the incidence rate, which I think is and the mortality analysis associated with that. The areas of the bowel on page 53, show a fairly consistent pattern of watershed areas of the bowel being involved in this type of vasospastic event, mainly that this, again, highlights the potential association with hemodialysis and ischemic colitis.
Do you intend to offer any opinions at trial in this case regarding cause of death?
No, I don't have any. I will not offer any opinion about cause of death.
In preparation for your testimony, have you reviewed any sort of pathology slides or any sort of slides of tissue or anything like that?
I have not reviewed any pathology slides.
Okay. And you have no intention of reviewing any pathology slides?
I have no intention of reviewing pathology slides.
Do you intend to rely upon any of the autopsy or pathology reports to support your opinions in this case?
I intend to rely on the surgical report, which describes the pattern of injury that was present at the time of the surgery on the 20th, on the 19th. The pathology report from the University of Maryland pathologist, I'm privy to Dr. Odzie's review of those slides in his deposition in terms of his review of those and identifying the resin in the small in the section which was of the distal ileum and colon. But I have not reviewed those myself.
Do you have any reason to disagree with Dr. Odzie's opinions with regards to the location of the crystals and their presence in the colon?
I have no reason to disagree with his opinions about the location and the presence or location of the crystals in the colon.
Did you also see in your review of the medical records, I believe it was when the bowel was first resected, there's a pathology report that indicates that there were crystals that were found consistent with Kayexalate in the colon. Did you see that in your review of the records?
That was in the autopsy report. In the surgical pathology report that was in the medical record, there was no mention of crystals at that from the initial surgical pathology report. It was at the time of the autopsy that was then brought up.
Yeah, we can take a look at it if you'd like. I know you got your stuff on PDF there. Let me take a moment. It was my recollection that the autopsy report was actually referring to the pathology analysis and indicated there were crystals.
The initial pathology report, if we can review that now. My recollection is that it did not specifically mention the presence of crystals. Right, this is the autopsy. The autopsy report is 1726 here.
Yeah, I think your page numbers may be slightly different than mine. Here we go. It's in the discussion section, I believe, of the autopsy report. You see that in the second paragraph, starting with the major findings at autopsy include cirrhosis?
Yes.
Okay. I believe it's the third sentence. Well, actually, third sentence. Prior colectomy specimen showed extensive bowel necrosis and hemorrhage. Ischemic necrosis is seen within the residual small intestine with scattered basophilic crystals consistent with recent Kayexalate use.
Yeah, no, in the autopsy report, it was definitely mentioned, but I think in the original, this was verified 2 months after May 17th, so this was done significantly after the event. But in terms of the original pathology report, which we'll have to locate here, I believe that crystals were not identified on the initial report.
Right. I guess my question,
Okay.
though, is, I mean, would you agree with me, though, that this appears to be referring to the prior colectomy specimen?
Yes, it is.
Okay.
Yes, it is.
So that was what was cut out during the operation on March 19th, correct?
Correct.
Okay. And that seems to be showing crystals consistent with Kayexalate.
The Kayexalate crystals do appear to be present in that specimen.
Okay. Does it change your opinion at all that the Kayexalate crystals were present in that area that was removed by the surgeon on the 19th?
No, because we know he was administered Kayexalate orally. I think that's proof that he received oral Kayexalate. It does not change my opinion in terms of causality.
Let me ask you about, this is going to be number 4. Actually, before we get into this, what are the typical signs and symptoms of ischemic bowel?
So most patients present with painless bleeding. And the differential for that in patients who, for example, would present to the emergency room with painless bleeding could include diverticular bleeding, ischemic colitis, bleeding from arteriovenous malformations, or rarely varices, rectal varices, stercoral ulcers associated with nonsteroidal anti-inflammatory drug use of the colon. So the majority of cases that I see as gastroenterologists with ischemic colitis present with either painless or mildly painful bleeding. And that's the majority of cases in that setting present in ambulatory patients mostly with left-sided ischemic disease that's mild, and those individuals usually can be managed conservatively, supportively, and don't require surgery. When this occurs in hospitalized patients, it usually presents again with bleeding. When it involves the right side of the colon, there's more likely to be pain associated with that.
Is there any difference between the presentation for necrotic bowel after a patient would be administered, for instance, Kayexalate, versus developing ischemic bowel as a result of hypotension?
There's no reason, in my medical opinion, no reason to expect any difference in how the cases present.
All right, another thing that looks like you intend to rely upon at trial is this, it's a Pocket Medicine 5th edition, and I have it exhibit number 4.
Okay. Yeah, I'm familiar, yeah.
Can you just tell me real quick, I mean, what is it about this that you find important to your analysis and opinions in this case?
So this Pocket Medicine, these are standard medical guides that hospitalists or internists would use for the management of specific conditions, and it speaks to what is considered standard of care, what a reasonably competent physician would do in a similar situation. It speaks to the knowledge of possible complications of any particular a drug that would be used in the situation. And so this is a 2014 edition. I wasn't able to get the 2013 edition, but there's no reason to expect that it would be any different from what's written here. And what it talks about is the possible treatment of hyperkalemia. Gives a nice table, which indicates that the drugs that should be used and why they should be used. It goes through the list, and then for Kayexalate, it's subscripted with a letter B, which is the only warning that is known and commonly known in the field, which is that there's a rare association with intestinal necrosis, especially with postoperative ileus or obstructive bowel disease. And it indicates the dosage that are typically recommended, 30 to 90 grams, that the onset is thought to be within 1 to 2 hours, and that it decreases total body potassium over approximately 6 hours by exchanging sodium for potassium in the gut. So this is a statement as to what the appropriate medical approach is to hyperkalemia.
Okay. Doctor, in your practice, how often do you typically treat patients with hyperkalemia?
As a gastroenterologist, I'm usually seeing the patients after they've been stabilized. So I haven't been treating acute hyperkalemia since I was a fellow moonlighting in the medical intensive care unit, moonlighting. But I treated this as a house officer. I treated this when I was, during my training. I was a hospitalist for a year, and then I treated it. So it's been some time, but the state of the art in terms of management of hyperkalemia has not changed in that time frame.
Could you tell me how long ago was it that you actually treated a patient with acute hyperkalemia?
It would have been approximately 2004, 2005.
Okay. And at that particular point in time, that, from my review of the medical literature, that would predate a lot of the studies that were done regarding the dangers and associations between Kayexalate use and necrotic bowel.
Well, I would disagree with that assessment. There's a paucity of data in this area. Much of it postdates the 2013 event. What has been published after that time frame were mostly editorial opinions and not primary data addressing the specific issue.
Okay. But you would agree with me, back when you were treating patients back in 2004 for acute episodes of hyperkalemia, at that particular point in time, it didn't seem like there was as much of an awareness of the association or potential association between Kayexalate use and necrotic bowel.
We were aware of Dr. Lillemo's work and the association of, when given by enema in postoperative patients, that there was a potential association in that setting.
Given your awareness of the potential association with Kayexalate back then, how often did you actually prescribe it to patients?
In terms of I couldn't tell you the exact number of times, but it was, my recollection would be that it would be somewhere in the order of 5 to 10 times.
Would you say, how many times have you prescribed Kayexalate in your career, if you could give me an estimate?
Probably about 10 to 15 times. I have patients now who have mild hyperkalemia coming in as outpatients, and we not uncommonly prescribe Kayexalate in those individuals as outpatients.
Back when you were handling patients with acute hyperkalemia, did you follow this particular, diagram of treatment methods with regards to the calcium gluconates, insulin bicarbonates, and then Kayexalate potentially?
Yeah, this protocol has been the medical standard approach for predating when I was in training. I can't state from before that, but predating when I was in training. This is every medical house officer undergoing training in the United States learns this particular protocol for the management of hyperkalemia.
So it's my understanding that when you have a patient with acute hyperkalemia, the first thing that you want to do is you want to stabilize the electrical charges regarding the membrane of the cell. Is that correct?
That's generally what one tries to do as part of the initial approach.
Okay.
Yes.
And you would do that with calcium gluconate or calcium chloride?
Typically, the preferable agent is calcium gluconate.
Did Dr. Allen, or Dr. Burks, I'm sorry, did he order the patient calcium gluconate in this case?
He did order calcium gluconate.
And did he actually administer calcium gluconate?
It was unavailable to him at the institution.
All right. Did you see any evidence in the record that he actually ordered calcium chloride as an alternative to calcium gluconate?
There's no documentation of an order of calcium chloride.
Is it your opinion in this case that Dr. Burks actually did order the patient calcium chloride?
I cannot make any comment as to whether or not he did or did not order calcium chloride. There's no documentation of an order for calcium chloride. That doesn't mean a discussion about calcium chloride did not occur. I can tell you that the one time I administered calcium chloride, it was a complete disaster. It extravasated the patient had a massive tissue injury of the arm and required plastic surgery. Unless my personal practice would be that I would not give IV calcium chloride other than through a central line. I would not administer that through a peripheral IV because of my personal experience with that particular drug.
You read Dr. Burke's deposition in this case, correct?
Yes.
Did he indicate that he was going to, or he attempted to give Mr. Allen the calcium chloride through a central line?
He indicated that he thought that he had placed that order, but in terms of the, I would have to go back and look at that specific point to recall exactly what he said in terms of the administration. He did indicate that he thought that he would have talked to the nurse about giving calcium chloride. Again, there's nothing in the record that I had access to that had any evidence that calcium chloride was administered or not,
Okay.
or that it was administered.
But it's your testimony that it would have been potentially an unsafe practice to actually try to administer calcium chloride, I guess, intravenously in a peripheral fashion?
Through a peripheral IV, it's generally not recommended, and some hospitals have a policy that it has to be given by a central line because of the severity of the venous injury that it causes. It's extremely caustic to peripheral veins. I don't know if the University of Maryland had such a policy at that time.
Besides what we've already discussed, and this may be beating a dead horse here, but do you see any evidence in the record indicating that Dr. Burks actually gave the patient calcium chloride?
There was no evidence that calcium chloride was administered to the patient.
Okay. What medication did he actually administer, with the exception of the KX? We'll get to that in a second, but what else did he administer?
He gave albuterol inhalers. He gave dextrose 50 with insulin. He gave something else, sodium bicarbonate, and he gave. So he ordered calcium gluconate D10, 10 units of insulin, sodium bicarbonate, and the K-Exalate. That order was at, I believe, at 12:37. At the 12:43, the insulin, another insulin order for 10 units was given, and then at 12:55, albuterol. There was another order for albuterol. And then again at 13:03, the second K-Exalate dose, the typical dose would be 30 to 60 grams. The second 15-gram dose was ordered at that time.
Leaving the KX-Lite aside for a second, with regards to the administration of the other medications that you just talked about, that's all standard of care, correct?
It's all standard of care.
Okay. Now, You haven't actually handled a situation like that, though, in your practice since 2004, where you've had to deal with an acute situation with hyperkalemia, where you've had to go through this protocol, correct?
No, I've not done it since I was when I was in the ICU. I had to do this. I have not done ICU work since about 2005.
Okay. In your review of the medical record, once the insulin, bicarbonate, albuterol were administered to Mr. Allen, did his cardiac situation stabilize?
Yes.
Okay. Those medications that he was just administered, how long would they still have an impact in stabilizing his cardiac situation?
Generally, at most 30 to 60 minutes.
And then the next step would be to find some method of getting the potassium out of his bloodstream, correct?
Correct.
Okay. And am I correct in saying that there's essentially two methods of doing that, Kayexalate or hemodialysis?
There are three methods. So Lasix in someone who is not anuric, which was not in this setting available. But the other two options are Kayexalate and dialysis.
Okay. When you were treating patients back in 2004, when you were dealing with acute episodes of hyperkalemia, did you ever have a situation where you preferred to treat the patient with hemodialysis as opposed to Kayexalate?
When you're an internist in an intensive care unit setting or intermediate medical care unit, when these events are occurring, you have absolutely no idea when dialysis can be available. It's not something that you set up. It's not something that you can even order. Typically, these things have to be, you have to get in touch with the nephrologist. The nephrologist there has to be availability of a machine. The machine has to be cleaned. There has to be a technician. Depending on where you are, there are certain requirements as to which type of room the patient can be in to receive dialysis. You have no idea if dialysis will be available in 1 hour, 2 hours, 3 hours, 6 hours. You have no idea. You also have the clinician in this say would have no idea if the dialysis would actually work. In terms of I've had experience where patients need to be dialyzed for uremia and their catheters don't work, and then you have to declot the catheter. So there's a lot of technical factors that at the time when Dr. Birx is making this medical decision that he has absolutely no control over. And so the typical response, and most reasonable competent physicians in this setting will do more than one thing to try to control the hyperkalemia. And the standard of care approach in this setting, in the absence of the specific contraindications that have been described, is to use Kayexalate.
How long does it take Kayexalate to actually have an effect on the level of potassium in the body?
It depends on how high the potassium is. So the higher the potassium, the more rapid the effect. It primarily works in the colon itself. The Kayexalate primarily works in the colon itself. So some of that will depend on transit time. So the faster the Kayexalate gets to the colon, the faster it works. But my review of the medical literature is that the onset can be expected in as short as 1 to 2 hours. And so that's why it is typically the recommended approach to, in this setting, even if dialysis might be available within a few hours, to administer Kayexalate.
Have you read this article? It's Management of Severe Hyperkalemia by Lawrence Weisberg.
Yes.
Okay. I wanted to ask you about one comment here and just whether or not you agree with it or disagree with it. Okay, this is, and you can take a look at this, but I'm going to read it to you first.
All
Do you
right.
actually have it available?
I don't have the copy
Okay.
of that. Sorry.
So the statement reads, and this is in regards to Kayexalate, when given orally, the onset of action is at least 2 hours and the maximum effect may not be seen for 6 hours or more. Do you agree or disagree with that statement?
There are other sources, and these are described again in the editorial, that suggest that the onset can be sooner than that. There are very few data as to how quickly the effect of K-isolate occurs. Now, one of the factors that needs to be considered in this particular case, and in any case, is that, and this is discussed in that article, is that rebound hyperkalemia occurs. So once the dialysis is discontinued, the potassium levels go back up between the end dialysis level and the pre-dialysis level by 35 to 70% over 6 to 12 hours. So while dialysis acutely does bring down potassium levels, particularly in the setting of severe rhabdomyolysis, there is very likely to be rebound. So the rationale for using K-Xylate is not just to bridge the patient to dialysis, but to, over the next 24 hours, try to prevent recurrent hyperkalemia that is extremely likely to occur in this setting.
When you talk about rebound likely to occur, how likely is it to occur?
It's nearly universal that it occurs. Once the patient stops dialysis, they stop clearing potassium. And if the muscle is continuing to dump potassium, breaking down muscle is continuing to dump potassium into the circulation, hyperkalemia will recur.
Can't the patient just be continued on dialysis?
That is, so there is potential for the use of continuous venous filtration, but that's not something that at the time of the initial decision that Dr. Birx would be able to would be able to look forward 6-7 hours to know if that was going to be possible. That would not have been possible in the bed that the patient was in at the moment.
Okay. So setting aside all of the potential for rebound, I mean, Dr. Birx has no idea whether that's going to happen or not happen at the time he's making the decision to administer the patient K-Xylate, correct?
Objection. You can answer.
So he may not know exactly to what degree rebound will occur, but it's known that rebound occurs, and in a patient who is anuric, the potassium is going to increase once dialysis is discontinued.
Let me read this.
Whether or not he was considering that at the time of his decision, I can't tell you.
In your review of Dr. Birx's deposition, did you see anything where he had indicated that he had factored that into his decision making?
That was not something that he discussed in his deposition.
I'm going to read you another sentence here, and I just want to tell me whether or not you agree or disagree with this one. The slow onset of action and serious, albeit infrequent, toxicity make SPS a poor choice for the treatment of urgent hyperkalemia.
I disagree with that opinion
And why do you disagree with that?
because the preponderance evidence is that SPS is safe in this setting, it is effective, and a reasonable competent physician would use it in this setting. The data that it is not effective is not conclusive, and that it's not safe is not conclusive.
Are you done with that article?
Potentially.
Oh, okay.
Did you want to
I'd
take a
just
break
like
or
you-
something?
I would like, no, I would
Oh.
like you to read the full name of it just so that I can find it after this deposition.
Sure.
Or
Wait.
mark it maybe.
Yeah, well, we can mark it. That's fine.
It's in Dr. Leo's.
Yeah, it's the you actually referred to this one. I think in one of the depots.
I know, but if there's so many articles floating around and so many names floating around, I want to make sure I can identify that.
Right.
So just, can I read it into the evidence then, or read it into?
Well, I'll read it into evidence.
Okay.
It's management of severe hyperkalemia, and it's Lawrence S. Weisberg, MD.
Okay. Thank you.
Doctor, real quick, are you familiar with the any of the materials that have been released by the FDA in regards to K-Xylate?
I was through the depositions, I'm familiar with the content of the FDA warning.
Okay. With regards to the FDA warning, there was one that was put out in 2009, another one, I guess, that was revamped in 2011, a label warning. And it says, cases of intestinal necrosis, which may be fatal and other serious gastrointestinal adverse events, have been reported in association with K-Xylate use. Do you have any reason to disagree with the FDA's decision or the support for that decision that there's an association between Kayexalate use and necrotic bowel?
Object as to form and foundation. You can answer.
I have no reason to disagree with the statement that the FDA made that there have been case reports of intestinal necrosis associated with Kayexalate administration, and they are referring to case series that have been published.
Wouldn't that suggest, in your medical opinion, that there is an association between Kayexalate use and necrotic bowel?
Objection. You can answer.
So I think that tells you, that says that there are case reports enough that the FDA would make a note of that. But if there were, in settings where there is where the FDA is compelled to really question the safety of a drug, they make much firmer, they take much firmer approaches. This is a warning that there have been associations so that physicians would be aware of that potential association, but that doesn't necessarily change utilization practice. The FDA often makes warnings that are not based on that are based on case-based data that is not always in practice something that one has, is actually sometimes detrimental to follow the FDA recommendations. For an example, the FDA made a black box warning for the use of certain gadolinium enhanced contrast agents for patients with reduced glomerular filtration rates.
With
Reduced GFR, and specifically patients on hemodialysis. This was based on a case series of two particular first-generation gadolinium agents, and there have been 0 case reports with the agents that we actually use in clinical practice. So now we are unable to get MRIs with contrast for patients on dialysis who have liver cancer, for instance, because of this black box warning that's based on case series with a different agent. So one has to look at FDA warnings as what they are. They're warnings, they may be based on case series, but they're not always based on complete epidemiological studies that really answer issues of causation.
There's another publication that's actually on the FDA website. It's the same page actually where I got this information regarding the warnings and the label updates. And I wanted to read this to you, and you can take a look at it if you'd like to as well. But it's just dealing with some additional information from the FDA on sodium polystyrene sulfonate. And the one section says alternative therapy in severe hyperkalemia. Since effective lowering of serum potassium with Kayexalate may take hours to days, treatment with this drug alone may be insufficient to rapidly correct severe hyperkalemia associated with states of rapid tissue breakdown, burns, and renal failure, or hyperkalemia so marked as to constitute a medical emergency. Therefore, other definitive measures, including dialysis, should always be considered and may be imperative. Do you disagree with that statement?
I don't disagree with that statement.
If that statement is true, then why wouldn't it have been more prudent for Dr. Birx to wait for the dialysis given Mr. Allen's stable condition following the administration of the albuterol, sodium bicarbonate, insulin, rather than simply right off the bat order and administer Kayexalate?
Objection. I think that's been asked and answered, but go ahead.
So he was, all of these events occur simultaneously. He was in the process of getting in touch with the nephrology fellow to get dialysis arranged as expeditiously as possible, having no idea exactly what that time frame would be. But this is a medical emergency that requires prompt action. The reason that there is a order set that he would be directed to is because this is a medical emergency that requires multimodal therapy. The Kayexalate is a standard and appropriate part of that multimodal therapy that may have both short-term and long-term potassium removal effects in these individuals and in individuals in this situation, and you know, these are all occurring simultaneously. He doesn't have time to. He has to react promptly and quickly to a medical emergency.
Hypothetically speaking, if Dr. Burks had known that dialysis could have been performed in as little as 15 minutes, would it have been a better option to simply perform dialysis on the patient as opposed to administering Kayexalate?
Objection to Foreman Foundation. You can answer.
Okay. I believe that even if dialysis had been available in 15 minutes, that the use of Kayexalate in the situation was appropriate and potentially would have benefit to the patient.
Okay. So whether or not dialysis could have been performed earlier in time makes no difference to the decision whether to order Kayexalate or not?
In my medical opinion, no.
In your review of the deposition for Dr. Burks, did you see whether or not he was aware of any of the risks associated with the administration of Kayexalate?
There was no mention of any risks in the documentation, either in the medical record or in his deposition, regarding the risks that he would have considered at that moment.
Do you intend to, well, strike that. Let me ask you another question, actually. In the times previously when you've administered Kayexalate to patients who are suffering from acute episodes of hyperkalemia, and I guess this would be back in 2004, before that, did you actually have a discussion with the patient before administering the medication to them about the possible benefits and risk of the medication?
No,
Why is that?
because this is a medication that is generally believed by most reasonable competent physicians to be safe. If one concedes that it's associated with intestinal necrosis, the risk of that injury, based on my review of the medical literature, is probably on the order of less than 1 in 10,000 cases, probably closer to 1 in 100,000 cases, based on the frequency that this drug is prescribed and the number of reports that have been in case series reported. When in a medical emergency, when there is a safe medication that is known to be effective and is known to have, is or is not known to, if the risks are thought to be extremely minor, a reasonable and competent physician would not obtain informed consent for use of that medication. We give aspirin routinely to patients who come in with acute myocardial infarction. We don't ask informed consent. But the risk of GI bleeding associated with aspirin administration with an MI is much higher than any putative risk associated with Kayexalate. So in a life-threatening situation, it would be inappropriate to obtain informed consent for a medication that generally is considered safe, such as this.
You would agree with me, though, that Dr. Burks was able to stabilize the patient through the use of the other medications besides Kayexalate, correct?
All of these medications were given simultaneously. The other medications, which are known to work for brief periods of time, were effective, and the patient responded and did not, fortunately, at that point in time, die of arrhythmic complications.
If those other medications are effective at treating the condition temporarily, why can't a doctor simply provide those or administer those medications and then have a discussion with the patient about the pros and cons, if you will, of administering Kayexalate?
In my medical experience with medications that are safe not known to have risks of any material risks. That would informed consent would never be obtained to use this, use that type of medication. We don't obtain. It's not standard in the medical field to obtain informed consent for risks that a patient would not consider significant. And when risks are of a very rare complication are so infinitesimally small relative to the potential benefit during that emergency situation, it would be inappropriate to delay therapy to obtain informed consent. It would never be obtained in this situation.
So it's not important to warn the patient about the potential material risks with regards to Kayexalate from your perspective, even though the FDA says that it's important for the patient to know it based upon what they have to put on the label for Kayexalate.
Objection. You can answer.
The FDA warning is for physicians, it's not necessarily for patients.
But isn't the whole purpose of warning physicians about it so that you could have a discussion with your patients about the things that could hurt them?
Objection. You can answer.
The point is of those is that if the FDA has to make if there is a case series that suggests an injury, the FDA feels compelled to make that. Physicians, that information is for physicians. But if the risk is infinitesimally small, that would not normally impact the physician-patient interaction.
What are you mentioned some contraindications before about giving the drug Kayexalate. Can you just kind of go through those again for me?
So the known contraindications are for use in the postoperative period or individuals with ileus or small bowel obstruction, particularly with rectal administration.
This is the same safety warning label from the FDA website. In that same paragraph where it's discussing the association between Kayexalate use and bowel necrosis, it says, do not use in patients who are at risk for developing constipation or impaction.
Individuals in whom the agent will not move through the bowel.
Was Mr. Allen someone who suffered from constipation?
No, and the nursing record clearly demonstrates that he was having bowel movements particularly with lactulose administration on every day, including the morning of the 18th.
Have you seen Dr. Burke's typewritten discharge summary from the University of Maryland between, it was days between March 11th and March 19th?
I'm not familiar with the specifically, but I believe it was part of the records that were administered.
You could try to find it for me if you'd like to.
Okay, sure. In volume 1.
I guess while he's finding that, are you aware that prior to the 18th, one of the drugs that Mr. Allen was on was lactulose?
Yes.
And what is lactulose prescribed for?
Hepatic encephalopathy.
It wasn't used for his constipation issues?
It was used for hepatic encephalopathy. It was started by Dr. Baum in 2010 for hepatic encephalopathy.
Does hepatic encephalopathy cause constipation?
No.
If you go to the second page,
We're referring to the discharge summary by Dr. Burks.
yeah,
Are we looking at the same thing? Let me see.
it's this right here. I'm not sure if that's the same
Is this
thing or not.
Yes, it's the same thing.
Okay. All right.
I'm going to
See-
look over his shoulder. That's my
Sure,
only
sure.
copy.
You see where it says review of symptoms?
Yes.
It says a 12-point review of symptoms was obtained, and aside from those mentioned in the HPI were negative, he, however, did complain of constipation despite being on twice-daily lactulose.
Noted.
Would that have been something that would have been important to Dr. Burks before he ordered Kayexalate?
Not, I don't believe so. So in my medical opinion, 7 days later, when the patient was having regular bowel movements with lactulose, that would not be a concern.
Is there any indication that he wasn't still suffering from constipation 7 days later?
Yes, there's ample evidence in the nursing records that he was having stools on a regular basis.
You haven't seen any notes in your review of the records indicating that he was still having problems with
I'm
constipation?
sorry, could you repeat that? You
Sure.
haven't seen any evidence.
You haven't seen any notes or evidence in your review of the records indicating that he was still suffering from constipation?
No.
On March 18, you mean?
Correct.
On March 18th, no.
Maybe I'm reading this note wrong, but based on my reading of this note, it seems to be indicating that he was on lactulose because of his constipation. Am I reading that wrong?
You're reading that incorrectly.
Okay. How can you just try to clarify it for me? Because it seems like he says despite being on twice daily lactulose.
This patient had hepatic encephalopathy due to his cirrhosis. He was on lactulose for the hepatic encephalopathy. The goal with lactulose therapy is to induce 3 to 4 soft bowel movements per day. The reason is to get rid of colon toxins that cause hepatic encephalopathy. During his hospitalization, he was somnolent but arousable, signs of hepatic encephalopathy. The reason he was on the lactulose was to try to treat the hepatic encephalopathy. Lactulose is a disaccharide. It is a non-absorbed sugar. It stays in the colon and acts as an osmotic agent. Colon bacteria produce acid by metabolizing it. The acid binds to ammonia, which turns it into ammonium, trapping it in the bowel so that it can be flushed out to remove ammonia-based toxins from the patient and the bloodstream. That is the reason that the patient was on it, not for constipation.
Okay. So despite the fact that he was on this, that this could cause more frequent bowel movements, nevertheless, there was documentation that he was still having constipation.
It states that in the record. What the patient meant as constipation in that setting is not, constipation is a very subjective term. I have patients who have 1 bowel movement a day and consider that constipated. I have patients who have 2 bowel movements a day who consider that constipated. Constipation is a subjective term that could mean different things to different patients. But the goal of therapy would be for him to have 3 to 4 soft bowel movements per day. It is a reasonable interpretation of that statement that means he was not having the goal 3 to 4 bowel movements a day that he was supposed to be having on lactulose.
Doctor, have you reviewed the order set? I think you referred to it, I think, earlier in your testimony.
Yes.
I just wanted to ask you 1 or 2 questions about this. Do you have it available to you?
I need to.
Okay.
Hang on 1 second.
You know, I may just be able to show it to him. It's a real quick question.
Okay. All right. I have it here somewhere, but there's so many papers.
I'll look at it when you're.
Okay. And we'll mark this as an exhibit. I lost track. Which one are we on?
5.
Okay. Did you get the numbers on all the other ones? Because I feel like...
You didn't say.
I actually do want to mark this, so maybe we'll make the management of severe hyperkalemia 5, and we'll make the order set 6.
And have the FDA.
Yeah, do you want to do the FDA? We'll do 7 and 8.
Might as well do that too. I agree.
Yeah, I'm missing a piece of that though.
This is 6.
That's 6. We'll make this 7 and this one 8.
I think I found it. It's this one.
That one looks slightly different.
Different.
Yeah. It may be the same thing, maybe it just printed off differently, I don't know. What I have are these.
Yeah, I see.
Sure.
Yeah, it's just printed out a little bit differently.
Okay.
What exhibit is that?
This is going to be 6.
Okay, and that's the hyperkalemia order set.
That's correct.
UMMC.
Yep.
Thank you.
All right, doctor, so this is just really a quick question here about this. You see where it says sodium polystyrene sulfonate?
Yes.
And right above that it says clearance, and it says for potassium less than 6 milligrams. You see that?
Mm-hmm.
Okay. At the time that Mr. Allen was suffering his acute episode of hyperkalemia, were his levels greater than 6?
Yes.
Okay. Would it have been following the protocol then to administer Kayexalate if his potassium levels were greater than 6?
It appears that that line is reflecting the selective repeat potassium level
I'm sorry.
below based on the
I
therapy
didn't get
ordered.
you.
Oh, sorry.
The
That-
selective?
For a potassium less than 6 milliequivalents per liter, select appropriate repeat potassium level below based on therapy ordered. So it's assuming that there was one of these therapies were ordered. And so I believe, yes. I mean, it's a little hard to follow the order here, but I believe that it has that here because it's referencing sodium polystyrene sulfate and furosemide, which are the two agents that would be administered prior to dialysis in the setting of severe hyperkalemia to start to mobilize potassium.
Okay, so for potassium levels less than 6, you wouldn't order those tests, right?
This is a little bit confusing as it's written because it says select appropriate repeat potassium level below based on therapy ordered.
Okay, so if you're not sure about
I'm not
what it
sure.
means,
I'm not
okay,
sure.
That's fine. I'd rather than, if
Right.
you don't know, then
I'm
that's
not
fine.
sure. I'm not sure.
Okay. All right, doctor. With regards to standard of care, we talked a lot about that. Can you just tell me, I mean, beyond the opinions that we've already discussed, is there anything else that you intend to testify to in trial?
I object as to the scope of that, but you can answer. If
Uh,
anything else comes to mind now.
I believe that we've covered most of the aspects for which I've been, for which I would offer opinions. We've talked about causality of the colitis. We've talked about the management of acute hyperkalemia in this emergency setting. I don't know if I would be asked about any other specific aspects of the management of the case.
Okay. Well, let's just, with regards to standard of care, okay, do you have any further opinions about whether or not Kayexalate should or should not have been ordered? Anything that we haven't talked about? I only have one chance to take your deposition, so, if there's another opinion out there, I'd like to hear it now as opposed to at trial.
No, I have the opinion that this was, that every aspect of the medication administration that was done in this setting is consistent with standard of care practice.
Okay. And we talked a little bit about informed consent, but do you intend to offer any opinions about informed consent?
My medical opinion is that for agents that have extremely low risk levels, that informed consent would not be standard care. And a reasonable competent physician would not obtain informed consent, even given these FDA warnings.
What is your understanding of informed consent in Maryland?
My understanding is that in terms of is that a patient in Maryland that the standard, and I don't remember it's been a little while since I remember the exact wording of what is considered what the threshold for informed consent is, but what most reasonable patients would want to know in a particular situation. But I'm not aware of in Maryland if there is a specific threshold that has been applied in terms of what the material risks are that would warrant such informed consent. In most medical practice in Pennsylvania where I practice, risk levels that are less than 1% are generally considered not considered to be material risks that would require informed consent in most situations in with an agent that's deemed to generally be safe. But that's going to be, it may be different in Maryland. I'm not sure.
What is the risk of potential bowel necrosis for someone who is administered Kayexalate?
Objection. I think he's addressed that numerous times before, but go ahead.
Well, you mentioned 1% in particular.
I don't. So based on the literature of the association, if one discounts that there could be unmeasured confounders that lead to that association, my estimate of that risk would be on the order of less than 1 per 10,000, probably closer to 1 in 100,000 or even 1 in a million, based on the denominator of administrations of polystyrene in the U.S. over this time frame. These estimates are limited by the paucity of literature in this area, but I don't think that there would be any disagreement in saying these are extremely rare events when they occur.
When you say that the risk of necrotic bowel because of the use of Kayexalate is not material, at least with regards to informed consent, is it because the risk of developing bowel necrosis is less than 1% in your opinion?
It's my opinion is that it's significantly less than 1%, probably on the order of 0.1 to 0.01%, if that high. And at that level of risk in an emergent situation, that information would not be material to the patient. This is a patient in an emergency situation needs to be, the level of informed consent in an emergency situation would be, the threshold of risk would have to be much higher in an emergency situation than in a routine elective situation. Routinely for colonoscopies, we tell patients about risks of 2 to 3 per 1,000, but that's an elective situation. In an emergency situation, as I mentioned before, aspirin use in acute MI, the risk is probably on the order of 2 to 3 per 1,000, but no one would ask for informed consent because it's a medical emergency. So in this situation, the risk is not material.
Do you know Richard Goldstein?
No.
I thought maybe you might because he's in the Pennsylvania area as well, and he's a gastroenterologist, but you never came in contact with him?
No.
You've reviewed his deposition, correct?
Yes.
Okay. One of the things that he indicated at his deposition, and I don't know if you have any of this available to you, but it's on page number 12. He's talking about ischemic bowel, and he says when you have truly deprived blood supply, it much more commonly affects the small bowel than the large bowel. Do you agree or disagree with that?
I disagree with that.
And why do you disagree?
Because the typical pattern in non-occlusive mesenteric ischemia is to involve watershed areas of the colon. That's much more common. In embolic events, you're more likely to involve the small bowel. But in non-occlusive, and this was a non-occlusive case, it is less likely to involve the small bowel and much more likely to involve the colon.
Okay. And those watershed areas that you're referring to, can you just briefly kind of highlight those areas for me?
So the ileocecal area and the splenic flexure, proximal descending colon.
Were those the areas that ultimately were surgically removed on the 19th?
Yes.
in your notes, and I'm going to mark your notes here as exhibit number 8, 9? 9. There, try to not cover up this info. All right, doctor, on the last page, it looks like you have some, it looks like notes regarding things that you disagree with regards to some of the plaintiff's experts in this case. Is that correct?
Yes.
Okay, and you specifically noted some things for Dr. Stearns. Can you just kind of run through those disagreements for me?
Yes, so Dr. Stearns holds that it was a deviation of the standard of care in the setting to administer K-Xylate. I disagree with
I'm
it.
sorry, I'm going
Oh,
to
sorry.
slow down.
He holds that it was a deviation of the standard of care to administer K-Xylate in this setting. I disagree with that and have provided literature supporting why I disagree with that statement. He says that the drug has no benefit. The literature do not support that the drug has no benefit. I think there's some controversy as to the timing of the effect, but I think particularly in this setting, with massive rhabdomyolysis, that the drug would have benefit. He stated that the incidence is 1 per 1,000. I don't think that the literature appropriately substantiates level of association at the 1 per 1,000 incidence level. So I disagree with that.
Are those the only disagreements you have with regards to Dr. Stearns?
Those were the predominant disagreements that I had with Dr. Stearns.
Okay. Are there any other disagreements that you have that come to mind now that we're talking about this?
Objection. You can answer.
I don't, there are no other disagreements that at this moment I can specifically recall. These were the main disagreements I had with his assessment of the situation.
Okay. With respect to Dr. Leo, can you kind of highlight those disagreements you have with his testimony?
So I highlighted in Dr. Leo the Weisberg paper that he cited to highlight the issue of rebound hyperkalemia, which it states rebound always occurs. It's the numbers are in that exhibit, 35% at 1 hour, 70% at 6 hours. This is important information in terms of why K-Xylate is actually potentially useful, and speaks to the benefit of K-Xylate in this setting, because dialysis is usually a self-limited. It's usually administered for a period of time, but in an individual who has a massive inflammatory myopathy, the dumping of potassium into the circulation would not end or be ended by the dialysis and would continue in the post-dialysis period. And Dr. Stearns had indicated that he thought that K-Xylate worked, but more over a 24-hour period. And this is speaking to why there would be a benefit in this case for the patient having received K-Xylate after dialysis to continue to be pulling potassium out of the system after dialysis is done, because rebound will occur.
Any other disagreements with anything in Dr. Leo's deposition?
Not, yeah,
You can answer.
okay, not that I can recall at this moment. Other than, again, his statement that the administration of K-Xylate would not be standard of care, which, as I stated, I believe is standard of care.
Can you describe for me your current practice as far as, do you see patients in a hospital setting, or do you have your own office and patients see you there?
I see patients in a hospital setting.
Okay. Do you also have any sort of outpatient services where patients come to you outside of the hospital?
I see outpatients in a hospital setting, so it's a hospital-based clinic.
Okay. So do you also see patients who are actually admitted to the hospital?
Yes.
Okay.
So I attend on the inpatient service as an attending gastroenterologist, and I see consults for patients who come in with acute GI issues.
When you consult with a patient, do you see them on any particular floor, critical care unit, intermediate unit?
We see the patient in medical intensive care unit, surgical intensive care unit, emergency room, med-surg floor, wherever the patient is at the time.
How many patients do you think you see on an annual basis who present with rhabdomyolysis?
So because I have a population, I have a large patient population with cirrhosis, I encounter generally between 1 and 2 cases of rhabdomyolysis in my liver patient population a year.
And of those patients that you encounter annually that have rhabdomyolysis, how many of those patients also have hyperkalemia?
I do not recall at the moment any patients with rhabdomyolysis that specifically had hyperkalemia.
The patients that you do see on an annual basis who do have hyperkalemia, are you currently treating those patients with Kayexalate?
Yes. So there's, these are generally patients with chronic kidney disease who are pre-dialysis. They're not acute inpatients with potassiums over 7. These are individuals with more chronic hyperkalemia, potassium levels in the 6 to 7 range, and we will treat those patients as outpatients with Kayexalate to keep their potassium under control.
Are those patients also receiving dialysis?
In my practice, generally, no.
Is there a reason why those patients are treated with Kayexalate as opposed to dialysis?
Because these are patients who have not quite gotten to sick enough uremic to the point where they need dialysis. So it's done in the pre-dialysis setting. Once the patients are on dialysis, they rarely develop hyperkalemia unless they are non-adherent and don't go to dialysis.
Based upon your review of the medical records, as of the 18th, was Mr. Allen someone who needed to be on dialysis?
As a non-nephrologist, I would feel it's a little bit outside of my scope of practice to make that medical decision at that moment in terms of does he need to be on chronic hemodialysis. Prior to the 18th, he had not had hyperkalemia. Prior to the 18th, his BUN levels were not in what is the typical uremic range for patients to need to be on chronic hemodialysis, but this was a patient who was clearly approaching flirting with dialysis, which is why he had a line in place. But the decision to put him chronically on hemodialysis had not yet occurred. I would speculate that he would have, he would, had he survived the hospitalization, would have been on chronic dialysis after the hyperkalemic event.
I wanted to ask you just a few questions here about your expert designation. Have you seen this, by the way, at all? It's the designation of expert that was filed by the defense in this case.
Sure, I can hand it to
And
him.
then just review the specifics of it.
It just identifies you as an expert and talks about potential opinions.
I don't want to misspeak. That's what it says there. Yes.
So you talked about a lot of these, but third sentence down, it says he will also testify as to the cause of ischemic colitis, Mr. Allen's life expectancy, and whether Mr. Allen was a suitable candidate for a liver transplant.
Okay.
You already talked about the causes of ischemic colitis, but do you intend to offer any opinions at trial regarding Mr. Allen's life expectancy?
I, as a transplant hepatologist, and knowing the patient's MELD score at the time of this event, would be able to make an opinion as to what his likelihood of surviving the next 90 days was from a liver perspective. His MELD score was 19. Let me just confirm that in my notes because I had it written down. I believe his MELD score was 19 at the time of this event. Well, actually, at the time of admission. By the time the event occurred, his MELD score was 26. That's actually noted in the hepatology note, the hepatology consultation note. And that's associated with a 20% 90-day liver-related mortality. So the MELD score is the model for end-stage liver disease. It's a calculation that is based on data sets that actually exclude patients with chronic kidney disease, but it is used for prognostication of liver survival, liver-related survival in patients with cirrhosis, and as well as for transplant allocation. So a MELD score of 26 is fairly ill, and a 20% chance of dying within 90 days of liver-related death. A MELD score of 26 would not typically in this region of the country be high enough for a patient to get a transplant in the short time frame. This particular patient would have been an extremely poor candidate for transplantation given his morbid obesity. His BMI was 44. Most transplant centers in the U.S. will not consider individuals with a BMI of greater than 40 meters per centimeter squared. And the reason for that, and particularly in this situation, he would have required both a liver and kidney transplant. The wound healing, the ability to close the wound, infection rates, cardiovascular complications, pulmonary complications are all markedly increased in individuals with BMIs over 40. And therefore, most transplant programs would not consider him a transplant candidate.
You said most transplant centers. Are there transplant centers out there who would consider him a candidate?
There,
Objection. You can answer.
okay, there are no official UNOS policies about a upper BMI. There's no UNOS policies about upper limit of age of patients getting transplantation. However, the data on terms of what individual transplant centers will and won't do is limited to survey data, which is limited, and the veracity of that is questionable. But over 50% of centers in surveys will choose a cutoff of either 35 or 40. Others will not specify a specific cutoff, but while centers may say that in terms of policy, when it comes time to evaluating a patient who is morbidly obese at a BMI of 44, in general, there will be a requirement that a significant amount of weight be lost prior to transplant in order for the surgeons to actually be able to close the incision.
You said that there is a 20% chance that within 90 days he could pass away as a result of his condition, correct?
From liver
Objection.
disease.
From liver disease.
From liver disease.
Okay, so there's an 80% chance that he would not pass away from liver disease within 90 days, correct?
Based on the MELD score. But in the clinical context of a patient with cirrhosis and severe rhabdomyolysis of unclear etiology, I would expect that it would have been extremely likely that this patient would have not have survived the hospitalization independent of the colitis event. If the patient had been diagnosed with an inflammatory polymyositis on the biopsy, the treatment would have involved high-dose corticosteroids. This would have been associated with extremely high infection rates and a very high likelihood of complications. So, the MELD score is really primarily used in ambulatory settings to prognosticate in liver-related death only. This is an individual with renal failure, liver failure, as well as bouts of circulatory failure with hypotension. He was at extremely high risk of complications of all sorts during this hospitalization due to the underlying insult, and unfortunately was at high risk of death in the next 30 days.
Based upon a reasonable degree of medical certainty, do you have an opinion as to his life expectancy?
Generally, individuals with a MELD score of 26 with chronic kidney disease, in my experience, generally have a life expectancy of less than a year.
Okay. Have you reviewed or have you looked at any documentation for any of the potential locations that Mr. Allen could have gone to in order to get a liver transplant or a kidney transplant and their requirements down in Maryland?
I have not. The hepatologist who was seeing the patient during the inpatient just said, come for evaluation as an outpatient. There was no statement stating the patient was a candidate or not a candidate, nor making any assessment of his transplant candidacy.
Just give me 1 second here to review the rest of the expert designation. Okay. Last thing, we didn't talk about this, so I want to talk about a few more things here that we have in your file. Let's just mark this as exhibit number 10. All right, so I believe we probably have already touched about what this is probably referring to, but can you just tell me real briefly why this particular excerpt or article is important to you?
So this is MKSAP 15, which is the Medical Knowledge Self-Assessment Program. This is used for board certification, initial certification and recertification for candidates in internal medicine, which is Dr. Burks' especially at the time of this event. In discussing acute hyperkalemia, I refer to the third paragraph. The second paragraph talks about combination therapy with glucose and insulin shifts potassium into cells.
Slow down a little.
Sorry. Administration of sodium bicarbonate helps to expand the extracellular fluid space and therefore dilutes the serum potassium concentration, but also may shift potassium into cells. Inhalation of beta-2 agonists and parenteral use of albuterol may cause a significant potassium shift into cells. However, although these therapies provide immediate relief of acute potassium toxicity, the improvement is only temporary. Interventions such as administration of sodium polystyrene sulfonate and dialysis help to decrease total body potassium content. And the reason that I thought this is important because it speaks to the medical standard of care that Dr. Burks would be held to in this case.
Okay. And I'm just going to mark the last two things here. It looks like this is going to be number 11, and this is just correspondence, email correspondence between you and Defense Counsel.
Yes, it was 93 pages, but I didn't want to kill that many trees, so I printed out multiple pages per sheet.
Sure.
So you need a magnifying glass to read that.
Yeah, no, it's okay. I mean, I did notice that one of the things mentioned something about possibly producing a report. You haven't produced any reports in this case,
no report
right?
was produced.
And it looks like you were first approached about testifying or reviewing the case back sometime in April of this year? I
don't recall exactly when I was first contacted. It was, I think it was by email, so it would be in the correspondence.
Okay. Do you know how Mr. Shaw found you for this case?
I believe that I am registered as a potential expert on a site. There was I'm not sure if I registered myself or somehow I got put on that list, quite frankly. But around that time I was contacted about a few cases, so somehow my name got on a list and I was contacted.
But this isn't a site that you pay for to advertise your services as an expert or anything like that, right?
I have not paid for any solicitation, and in general I have I have generally not actively solicited expert business in the expert witness industry.
So we'll make this number 11. Besides the email correspondence, have you received any sort of written letters or anything like that from defense counsel?
Everything has been by email,
Okay.
and I'm happy to provide a PDF of that correspondence if you prefer.
No, that's fine. We'll just attach it to the depot. Last but not least, it looks like these are invoices for legal consulting services over the last few years. Is that correct?
The last 5 years.
Last 5
That
years.
was requested by Mr. Gaston, I believe.
And what is DEK JHK Medical Consulting LLC?
So that's a corporation that I have for for my consulting work. Most of my consulting is in CME areas, so I have a corporation for my non-primary for my consulting work.
Okay. So we'll mark this as Depot Exhibit number 12. And Doctor, just real quick, have we covered all the opinions as we sit here today that you intend to offer at trial?
I object to that because I'll let him answer to the extent that he can recall right now, but there may be things that occur at trial. There may be other opinions he has to address. So I believe he's covered in at least broad brush fashion his opinions, but I'm always concerned when an attorney asks that question that if he doesn't voice an opinion at trial almost identically to the way he voices it at deposition, there will be an objection. So I can tell you that he's going to say things and express things somewhat differently probably at trial than he has here, because he's going to be responding to my questions as well as your questions. So I object to that, but I'll let him try to answer.
To the extent which I can recall at the moment, I believe that we have covered the aspects that I would be asked to discuss at the time of trial.
Okay. I have no further questions then. Thank you.
I don't have any questions. I do want to make sure that we have, and maybe we already have, but that we've marked as an exhibit each of the documents that were produced by Dr. Kaplan and copied.
I think we did. I
Have we
went
marked
through
it-
everything.
Marked each of those?
Yeah, we should
So
have.
there should have been 4 different items, is that correct? 5 different items, no more than that. I mean, as far as the medical articles,
We went through both those articles. We went through the
Those four,
nephrology, MKSAP 15, and the pocket medicine
and
manual.
the pocket medicine, okay.
Right.
so 1, 2, 3, 4 in my notes.
Okay.
Yeah, I think we
All right.
covered everything.
All right, good, as long as we have those marked. All right, I don't have any questions. I assume we can go off the record?
Yeah.
This concludes the video deposition of David E. Kaplan, MD. We're going off the record at 2:14 p.m.